Hello, everybody. This is Dr. Robert Lillard, Medical Director for the Cumberland Pediatric Foundation, and we are back again to talk about more infectious disease fun. And I tell you, if 2022, if you started out with a bingo card that had Omicron variants, polio in New York City, and monkeypox, you're going to be a winner. But we've had a lot of questions about monkeypox, and so we are here today, joined again, fortunately, by Dr. Buddy Creech, who is Director of the Vanderbilt Vaccine Research Program. And Buddy, thanks for coming in again so we could talk about this and help our members understand what's going on.
Absolutely. I am not a monkeypox expert, but I did sleep at a Holiday Inn last night that had been properly disinfected, so I should be good.
Yeah. That's the case. Okay, great. All right, well, let's spend a minute talking about monkeypox, the history of it, what it is, where it came from, where it's more endemic, and yeah, tell us.
Well, we first knew monkeypox was a thing in the 70s when some monkeys in Denmark that were being used for polio research developed pox lesions, hence the name monkeypox. Those monkeys originated in Singapore, but we know that this is a virus that has circulated in outbreaks and somewhat regularly throughout Central and West Africa. And there are two different clades, or maybe we think of two different virus families within the monkeypox group. One called clade 1, which is the one that has typically circulated, and one that's clade 2 that really took off in Nigeria in 2017, 2018 during an outbreak, and is the basis for our current multinational outbreak that we're in right now. You know, monkeypox is very similar to cowpox and smallpox, which forms the basis for some of our understanding of the disease, the risk factors involved, the clinical manifestations, the treatment, and then ultimately the vaccine. So it's an older disease that probably began to emerge in humans because of the lack of smallpox vaccination moving forward. We know that the smallpox vaccine was probably keeping some of these at bay for a good long time.
Okay, great. All right, so it's made its way here. How do we think that happened? Let's talk about transmission and try to understand some of the aspects behind that.
The real challenge is that this outbreak has been different than previous outbreaks. Most have started with a great deal of interaction with animal reservoirs that have disease. So in this case, close contact with a monkey or some other smaller animal that's been infected with monkeypox. In this current multinational outbreak, it's been unique in that it's been primarily sexually transmitted. We've always known that this was a direct contact disease. You touch the lesion, or maybe through fomite spread, meaning the lesional fluid can then infect bedding or other materials that could then be a source of transmission. We've always known that this could be spread in a respiratory manner, right? With the respiratory droplets being a way to spread it. This one has been different in that it's been principally till now sexually transmitted, and it's been in predominantly men who have sex with men. And there's nothing unique about that population necessarily, other than there's been a high amount of transmission among some relatively closed communities. And because of that, we've seen it principally among men who have sex with men or their very close household contacts.
Okay. And now, there have been some reports, though, of being outside of that realm, obviously, and how concerned we should be. Let's talk about fomites, for instance, bedding and things like that. How concerned should we be about that process, and what, maybe we think about what we should do in our office after we see patients with rashes, or for our own safety, what should we be thinking about?
Yeah, there's so much to unpack there, because I think we're a little bit early to understand all of this, but in general, we know that pox viruses can survive in the environment for a pretty long time. Think about smallpox vaccine, or smallpox as a disease. It was spread through blankets and clothing, even in early colonial times in the U.S., as the British were using it as a bioterrorism agent against our Native American population. What we know is that probably for at least a week or two, the virus can survive on untreated bedding and especially porous surfaces, although admittedly that ability to spread in that manner is going to decrease over time. But that has more implications, I think, for infection prevention of confirmed cases, rather than a sky is falling Chicken Little approach to every piece of clothing or bedding or fabric that doesn't belong to you. Right now, we're at a point in the epidemic where the best way to prevent our kids from getting monkeypox is to not get monkeypox ourselves. The best way that we can prevent spread is to make sure that those who have symptoms consistent with monkeypox are tested, treated, and dealt with in terms of infectious capability a little differently. So what does that mean for the clinic provider, for the office provider, for someone working in an urgent care? Well, it typically would mean that anyone with a rash illness, we really need to ask questions related to exposure to those with confirmed or suspected cases of monkeypox. That's still probably our leading question, because really testing right now is principally directed at those with an epidemiologic risk factor, as well as a characteristic illness. Now, the characteristic illness is the part that for adult providers, maybe it's not so hard, but for pediatricians like us, good grief, febrile rash illnesses are less than a dime a dozen. They are cheap. And so we've got to really be thinking about this. So typically the prodrome for this disease is fever, achiness, a flu-like illness, sometimes lymphadenopathy that's really out of proportion to the illness. And that's typically followed after 2 or 3 days, maybe 4 days, with this characteristic rash that starts as a papule, then sometimes a vesicle stage, although it may skip that, into this pustule. And it's not just like a boil, right? If you see a boil that looks like staph, it's probably staph. But it's this deep-seated, well-circumscribed, sometimes umbilicated pustule that is often hard and tense, and it looks like what you've seen pictures of for smallpox. They're often on the face. In cases of sexual transmission, they're typically in the genital area, and we've had a lot of individuals develop proctitis or anogenital lesions because of this virus. And then you're contagious until those scab over and you start to see re-epithelialization. So I think that's a really important piece for us as pediatricians to think it's not just every blistering rash. It's not just every hand, foot, and mouth disease that we suspect that we now all of a sudden have to test for monkeypox on. It's, do they have a rash illness? Is it unusual in the type of circumscribed, deep-seated pustular lesion that it is? And do they have a known exposure to somebody either with monkeypox or who's at very high risk for monkeypox? I think that's where I would start for right now.
Okay. And for those of us who used to see chickenpox all the time, it's I guess somewhat similar in that you'll see the rash at different degrees of development, but will these be a little larger than your typical varicella type lesions, or?
They're absolutely larger. They don't have, unless very fleeting, they don't have that characteristic dewdrop on a rose petal formation. These are deeper seated. These are not flaccid vesicles that pop if you just look at them too hard. These are thicker walled pustules typically. And the challenge for us too, I think, is that the clinical manifestations are going to be variable. There are some people who describe just a few lesions. There are some who have thousands of lesions that primarily affect the face. So I think it's going to be really challenging until we get a better handle on how this milder version of this monkeypox virus is going to handle itself in kids.
Okay. And do they typically explode, or is it more kind of a, you see 10 and then 20 or 30? And I'll bring up a case that came up the other night. Was a child who had eczema and really looked like either probably eczema coxsackium or eczema herpetiformis, really had a fever followed by just an explosion of lesions and a lot of grouped vesicles and things. Would that be something you would look at that and say, I should test that for monkeypox, or would that be a little unusual? I mean, these were small lesions too.
Yeah, I think that's a little more unusual. And I think while children with eczema, because of that altered T cell immunology, they may be at greater risk of monkeypox complications should they acquire it. They're not necessarily more at risk for monkeypox. They still have to have that epidemiologic link. In terms of the lesions themselves, I think it's really, we're still trying to figure it out with this particular clade virus and this particular exposure history that most people have, which is having sexual contact with someone with monkeypox. The anogenital lesions are showing up at different times. They're usually not just going to emerge while you're looking at them, although there have been some reports of very rapid distribution of these lesions. And so my sense is that they're not just going to be popping up sort of like the book Chocolate Fever. They're going to be a little different than that.
Okay. I'm going to back up for a minute, but before I do that, let's talk about if you've got lesions that you're worried about. Let's talk about testing and what to send off. And I know it's recommended to use viral transport media, and I'll ask you specifically: should you be testing for other viral agents if you're concerned, like herpes?
I think that's a really important question, and let me lead with saying we would be happy to help out with this through Peds ID, because I think if you're testing for monkeypox, we need to know about it. We need to be able to walk alongside you and make sure that we get all of the samples tested correctly. They have to go to specific labs. Our public health department is supporting this initiative. There are ways that we're going to try to diagnose it, principally through PCR from the lesion itself. And so I don't know that that's what most people are going to want to do in the office. That's probably something that we'd love to get them into the emergency department, put them in a negative pressure room. While we don't think this is an airborne circulation, typically, we're still going to wear N95s, wear personal protective equipment. We're going to go to that trouble, especially if we're going to start messing with a lesion, right? And then we send that off for PCR. And yes, in many of those cases, we will think about herpes simplex virus, especially if it's in the anogenital area where HSV could also emerge. We could also do things like intervirus PCR for hand, foot, and mouth disease. We could look for varicella, especially in someone who's non-immunized, or if they have a dermatomal initial appearance to this. So there will be extra testing. And then we can do serologic evaluations like an IgM, but again, those are being handled by certain labs. And until we get all of the referral labs up and going for testing, I think the easiest thing is to try to coordinate some of that testing with us.
Okay, good to know. And I just, like you mentioned the N95s, but that's, first of all, I guess we have to keep in mind there's really the only pediatric cases we're aware of have been direct contact with adults. We shouldn't necessarily panic about the respiratory component of this, as far as we know, right? We shouldn't all be.
I think that's right.
Back on in the office.
Yeah, I think that's right. I think what we know from the previous outbreaks is that sustained, prolonged exposure is what's needed. So it's really household contacts. And maybe a semantics issue is that some of those pediatric cases are direct contact with lesions. Some of them are just merely household contact where there is prolonged exposure, whether that's respiratory based, whether that's fomite based. I think it's still a little early to know for sure.
Okay, good to know. And what do we know about the possibility, and I hate to ask this because I remember back to COVID when we said initially people were saying asymptomatic transmission does not happen. Do we know? Because there have been some cases with no symptoms that have tested positive. What's your advice on that?
Yeah, it's hard. If it's happening inefficiently, because the most efficient way to spread this infection is through lesional contact. That's where the bulk of the virus is. So for those who are truly asymptomatic, who may simply be shedding a small amount in their respiratory tract, it's already an inefficient respiratory spreader. That just makes it even more inefficient. So I don't think that's the primary mechanism by which people are going to be infected. With that being said, we don't yet know what we don't know. And right. I don't want us to get too distracted on anything other than the biggest reason we should suspect monkeypox in a child is that they have a known exposure to someone who has monkeypox or is in an extremely high-risk group for monkeypox. And then the second is that they have a characteristic prodromal illness that is followed by the development of lesions that are pustular in nature. I think that's what we should lock and load. That will keep us from sending monkeypox testing on every kid with a little bit of infected eczema or hand, foot, and mouth.
Great. All right. So let's then launch into if this continues to progress and we have to worry about how we handle this and prevention. First, let's talk about treatment. And of course, the medication that we talk about the most is TPOXX. And tell me about treatment. Is TPOXX approved for children? Dosing and how that works?
Yeah, so TPOXX or tecovirimat is a fairly active agent that we're using. I can't say we have widespread use because the distribution has been a little hiccupy so far, but we do have it available. It's available down to about 13 kilograms of body weight for the oral formulation and to 3 kilograms for the IV formulation. The biggest difference there, of course, is that the IV formulation is a bit more toxic because of the carrier protein, and it's associated with a bit more acute kidney injury than the oral version is. But we do have it available for high-risk individuals, and those high-risk individuals are going to be, at least right now, anyone who's infected. We certainly have the ability to get it, but it's really those who have underlying immunodeficiencies, particularly cell-based or T-cell immunodeficiencies, and those that are less than 10. If you look at the African outbreaks that have occurred, the mortality rate in children less than 10 is in the low double digits. Now, granted, these are in often resource-limited areas. Diagnostics aren't available. There's just a different epidemiology for sure, and it's with a more severe virus. But I think we need to recognize that this is not a disease to be trifled with in our children that are less than 8 to 10 years of age, whether that's because of the development of pneumonia or encephalitis, myocarditis, or most commonly bacterial sepsis because of the intense itching and burden of these lesions. And it should make us think back to chickenpox, when those kids would get super infected with group A strep in particular.
Okay. And kind of bridging that into prevention and vaccination, if you have that situation comes up where you have a child and maybe 1 or 2 adults in the household have been diagnosed with monkeypox, do you use TPOXX as a prophylactic agent, or do you move into more vaccine? And then let's talk just a little bit about the vaccination strategy.
Yeah, in a perfect world, once that diagnosis is made, we could get a vaccine into that child within about 4 days. That would be the ideal window. And then if we can't do that and there's breakthrough disease, that's when we would reach for tecovirimat or TPOXX. The vaccines that we have available, we have 2, technically speaking. We have ACAM 2000, which is the traditional live smallpox vaccine that we have reserved for bioterrorism activities and for our warfighters, where we would use this bifurcated needle. For the older pediatricians, you remember this, of dipping it into the vial and then using scarification. So multiple depressions into the deltoid that would lead to a scar. And the better the take, the better the immune response. So it forms a pustular rash at the site, and it's capable of auto-inoculation and all kinds of badness. We're really trying to stay away from that vaccine if at all possible. It also is associated with myocarditis in young soldiers, particularly males. That resembles our COVID-19 myocarditis from mRNA vaccines in those that were naive to smallpox after 9/11. The better vaccine is called Jynneos, all capital letters, so it's kind of weird. But it's a modified Vaccinia Ankara that's made by Bavarian Nordic, so MVA. Now, MVA is really interesting because it was identified and grown in Germany after being recovered from some Turkish calves and donkeys. And it was passaged in mammalian cell or chicken fibroblasts multiple times, like 500 times, so it can't grow in mammalian cells. So yes, it was a live virus. And yes, if you put it in chicken cells, it's going to grow like crazy, but it cannot grow in mammalian cells. It's lost enough of its genome that it can't do that. So for us, we can treat it like an inactivated vaccine. And that helps us a lot because we then have used that vaccine not only in the late 70s in Germany, where over 100,000 people received the old version of this while smallpox vaccine was still happening, but the newer version has been used for a carrier, kind of like the adenovirus for the Johnson & Johnson vaccine. This pox virus can be used to carry other DNA from other things. So it's been used as an HIV, tuberculosis, malaria, and even Ebola vaccine. And in the last Ebola virus vaccine study that was used, using this modified Vaccinia Ankara, over 3,000 children down to the first few weeks of life were vaccinated. So we have a really great safety profile and safety knowledge of this vaccine. So right now, the EUA is for anybody and everybody can get the vaccine subcutaneously, much like we would do with measles, mumps, rubella. Over 18, you can actually fractionate the dose, get it to about 1/5 of the dose, and you can actually administer it intradermally like you would the older TB skin test that we do. That's a little bit harder for some groups to do. They haven't done that in a while, but that isn't yet approved for little kids. They would still get the regular subcutaneous vaccine. And the biggest side effects of it are about 85 or 90% of people will have pain at the injection site. About half will have some pretty significant itching Some will have some swelling and redness, and some will get a little bit of hyperpigmentation that might last for a couple of weeks. Those are the biggest side effects. We don't see anything much broader than that, other than the normal, feeling achy, maybe having a low-grade temp for a couple of days. So we're using that as both prevention in high-risk groups, as well as post-exposure prophylaxis, particularly for those kids who are in a household with someone who has monkeypox confirmed.
Okay, perfect. Well, that's a lot to take in, and we hope that we never have to deal with it. Let's hope that we can contain what's already shown up, and I guess the coming weeks will tell us a lot as far as that goes. So I want to thank you again for enlightening us about monkeypox, and to the members who watch this, if any questions come up on how to manage things, or what to do in general to prepare for this, please reach out to us. We can contact Dr. Creech as well. So, and if anything else comes up, we'll be right back here to talk about it. So thanks, buddy, for coming in.
Thanks, Rob. Appreciate it.
Take care. Bye-bye.